Good afternoon, everybody. Thank you so much for joining us today as we are going to be going over successful ACO reporting, excelling in the depression screening measure. This is our fireside chat. It's been a little bit of time since we have done one, but the way that the fireside chat's going to work is I'm going to MC and I am going to introduce our panelists and they are going to talk it over. But one nice part about I'll ask questions and then they'll talk it over. One nice part about our presentation is that you can ask questions as well. So there is a question section down the bottom. If we don't get an opportunity to answer them today during the call, please be assured that after the webinar, I will get those questions out to our panelists, or if there are things that I can answer myself, I will. All right, so today I'll get to who's here in a minute. We're gonna introduce each one of them individually, but just for your notion, there's the question section, and then the handout section's there as well. I have a copy of today's slide deck, as well as a little information about our ACO impact program, APP impact program that we have here. So first up that I'm going to introduce is our longtime partner with the American Psychological Association, Vale Wright. Hello, Vale. Would you like to tell us a little bit about yourself real quick?
Yeah, thanks, Mike. Hi, I'm Vale Wright. I'm a licensed psychologist by training, and I serve as the Senior Director in the Office of Healthcare Innovation at the American Psychological Association. And what we're really focused on is the intersection between technology and data and healthcare, and how we can use things like data registries, measuring care to improve both access to care and efficiency within care. And so it's a real pleasure to be here today to talk to you about these topics and to be joined by these colleagues. So thanks.
Great, thank you, Val. Really appreciate you coming on here. All right, and then next up, we have both Carly and Brett. Carly, you want to go first real quick? Tell me a little bit about yourself, and then we'll head over to Brett.
Sure, you bet. Hi, I'm Carly Madsen. I'm the Vice President of Go-to-Market and Customer Experience here at Videra Health. We're a digital health platform that helps connect with patients and scale your clinical capacity. In my previous career, I ran ACOs at a Fortune 200 company. And so I'm really excited to get to talk with all of you.
Great, thanks, Carly and Brett.
Good afternoon, everyone. I am Brett Talbot. I'm the Chief Clinical Officer and one of the co-founders at Videra Health. I'm also a licensed clinical psychologist by training. Spent my early career in outpatient and inpatient care, eventually becoming a Chief Quality Officer focused on leveraging technology for routine outcomes tracking and screening and monitoring, specialized in diagnostics and assessments clinically, and excited to talk a little bit today about how technology can improve our processes.
Great, thank you very much, Brett. All right, so next up is why are we here? That's the main thing. I'm going to go over a couple slides why we're here today. Why is this so important, what we're discussing? Obviously, besides the impact on our patients, but the main reason is that CMS has the ECQM, CQMs that are coming out. People are already reporting them, groups are already reporting them in 2023, some did it in 2022, but all are mandatory. The ACOs, the MSSP ACOs, all need to do it by 2025. So one of the main measures is the preventative care screening for depression and follow-up. As you can see, there's also a diabetes measure and controlling high blood pressure. The main reason we really are here to talk about the depression screening is, under my opinion and talking with the ACOs that we've worked with, it is the most difficult measure when it comes to the ECQM, CQM portion of your quality scoring in the APP. The reason that is because it includes way more patients than the other providers, and it also doesn't include an ICD-10 code to put the patient into the measure, right? So every patient that doesn't have diagnosed with depression or bipolar disorder is eligible for this if they're 12 years or older, and you need to do it at least once a year. So that population from before was, a little bit smaller because we're talking about just Medicare, but you're now talking about every patient that's coming into your facility, 12 years or older, needs to be asked the depression screening question. Whether they have depression or bipolar disorder will eliminate them from you needing to do follow-up and setting a follow-up plan, right? So now we're looking at all patients. There are 79 different encounter codes, so they don't limit the encounter codes to your 99212s or things like that. It includes a lot of encounter codes. The place of service can't be home. Telehealth visits are denominator eligible. You need to make sure that you know that. The denominator exceptions are patient refusal and medical reason, cognitive function, motivational limitations, or the patient is in urgent or emergent situation, basically meaning that it would do more harm for you to stop whatever you're doing to ask these questions than it would for you to move forward with them. Now, what makes up the numerator for this measure is that you need to have a screen for depression on the day of the visit, or, right, there's a big or and important to what we're talking about here, 14 days prior to that visit. So also you need the use of an age-appropriate standardized tool. If you want to go onto the APA's website or our website, or I'm sure on the Videra website, there are lists of what these standardized tools are for each one in this measure. If it is positive, so the patient is positive for depression, a follow-up plan must be documented on the date or up to 2 days after of the encounter. Standardized depression tools, wow, normalized and validated depression screening tool developed for patient population in which is being utilized. Now, the important part here is that CMS offers examples, but doesn't limit it just to those choices that they have on their examples as well. Most recent quality data code submitted will be used for the performance calculation. So it's not like other measures where it's any visit once during the year. This measure, it is done only when you do a depression screening. Did you do a follow-up? Must be in there on the last time it was done during the year. All right. Follow-up plan must be related to positive depression screening and contain one or more of the following: referral to a provider, pharmacological interventions, or other interventions or follow-up for the diagnosis of treatment. They really leave it pretty wide open, but I can tell you from experience that they want an answer there. They want something, a step that says you need to go do this. What's the next step? Performance is not met when depression screening is not documented, reason not given, so there's no exception for it, or the depression screening is documented as positive, but there's no follow-up plan. That unfortunately happens a lot in documentation in an EMR, rather than they might have talked about it with the person. I'm sure the doctor's doing that, but actually putting it in the EHR is very important. So I am going to get off this screen real quick, and we're going to start with our questions. Give me 1 second here. And everybody gets to hear the chorus of my dog in the background, so much appreciated, Miss Kiwi. All right. So my first question, I'm going to go to Vale, and then we could keep going. So what is measurement-based care, and how is that similar or different from the quality reporting?
Yeah, thanks, Mike. And again, it's a pleasure to be here. I think I'm gonna actually start in the reverse. I think a lot of people in this call are really probably familiar with quality measures, right? They're using process, structural, or outcome measures to demonstrate that what you're doing is working in one way or another. And often we use these quality measures to meet requirements for value-based payment models, like what we're talking about with MIPS, or for accreditation standards, like with Joint Commission. And so often they become a check the box activity. But I think what we're hoping people will think about today is how do you take this requirement to engage in quality measurement and use the infrastructure, build an infrastructure in place to actually use those data to drive decisions within the healthcare that you're providing. And that's what measurement-based care is really. It's really about how do you use these data in a routine manner to not just check a box or to demonstrate quality, but to actually improve the work that you're doing. And I think, when you look at that slide that had the measures on it and you saw the diabetes measure and you saw the high blood pressure measure, those are probably pretty familiar to you. You understand how to track those data over time, what an A1C looks like and how it improves or doesn't improve. And I think there's this real misnomer that you can't do something similar with mental and behavioral health care. And the reality is you can. The data may not look the same. It's not the same kind of vital sign data, but we do have really well validated, reliable measures for how we can determine whether or not somebody meets is a trigger for depression, for anxiety, for other mental health disorders. And the key part of this is that we have to begin to think about how do we integrate physical and mental and behavioral health care together. Because we know, and depression is a great place to start because depression is both common and incredibly treatable. And we know that before COVID, we had a mental health crisis in this country. This is not news. And that's only been exacerbated since COVID, where data has been really consistently showing that individuals are reporting increased rates of depression, suicidal ideation, alcohol use, anxiety, et cetera, particularly in younger and adolescents, adults. So I think focusing on depression as a first step to think about how do we provide more integrated care is a great place to start. And the other reason why depression is so important is it also has often a lot of co-occurring physical conditions. So if you have someone with depression, they might also have cardiovascular disease, asthma, diabetes, hypertension, obesity. They're also more likely to be smokers. They're more likely to have increased alcohol use. So just we know from the data that just treating depression alone actually has positive impacts on physical health outcomes, even if you don't do anything different with those physical health outcomes. So you may be not changing your diabetes treatment at all, but because you're treating the depression, their diabetes treatment actually gets better. Their outcomes get better because they're better able to cognitively pay attention to complying with medication routines. They're more motivated to actually do the sorts of things they need to do to protect their physical health. So again, these are really, really intertwined. And so why screening is so critical is that, believe it or not, even though we've come a long way, I think, in terms of stigma and understanding how important our emotional well-being is, most individuals still do not present to primary care or specialty care doctors reporting sadness, anhedonia, or depressive type symptoms. And there's a variety of reasons for that. One is, even though we think depression is sobbing and crying and not being able to get out of bed, that's only a subset of how it presents. In different populations, it can present really differently. So with men, for example, it often presents as anger issues and alcohol use, not sadness and crying. In adolescents, it's usually irritability, which can be really hard to distinguish from what might be developmentally appropriate for an adolescent versus what might actually be a mental health issue. Same thing with older adults. Oftentimes they'll present with cognitive issues that can get confused for dementia or other types of impairment. And finally, different cultures, including communities, individuals from communities of color will often present with somatic symptoms, so physical symptoms. So again, not emotional symptoms. So if we can start routinely screening for these types of issues and not just think of it as a checkbox sort of activity, but how do we think about, how can we think from a holistic way of how we treat individuals within our population? Because really, this is a public health emergency when you think about it. It's a whole population of individuals that are getting sicker and sicker. Depression has a huge disability component to it in terms of cost for both healthcare, but also for society. So I think that's why we're really here talking about how do we really capitalize on measurement in a way that is more meaningful, and how do we think about depression as a starting point when we're trying to think from a holistic point of view for a patient. I know that was a lot, and so I wanted to make sure I think Carly wanted to jump in and see what you have to say about that.
Yeah, thanks, Val. I totally agree. And I think like the really interesting thing is it gives depression screening gives a really great opportunity to risk stratify for your population, like you mentioned. So when we were running ACOs in my previous role, we had one reporting period where 70% of our emergency department admits were tied to behavioral health issues. That even though we were doing screening, a lot of those were presented in other more physical ways, but ultimately it tied back to behavioral health issues. And so there's a huge opportunity to manage from a cost perspective, not only quality, but also cost, which we know we're all focused on by doing these screenings and identifying proactively and early before it starts manifesting in other ways.
Great conversation there. And please always continue to jump in and hop in all over the place once we're done. So the next question I have, and I'm going to put this towards Brett and get him started here on this, but what are the benefits of engaging in routine screening and assessment for ACOs and patients?
Yeah, there's a long list of benefits, which, we all are probably familiar with many of them, being able to screen and monitor over time. As a clinician, as a provider, a few that I wanted to highlight just from a clinical perspective of the benefits of doing that. Again, as Vail said, depression specifically and other mental health issues are hard to quote unquote see. There is no oximeter, there's no glucometer, there's no like peripheral device that you can attach and see depression or anxiety or suicidality. And so doing these types of routine monitoring and screening is important for that early identification. We know that if we can early identify it, it is depression specifically very treatable. Lots of well-researched and evidence-based programs and workflows and treatments that we can get patients on if we meaningfully identify them. And that really switches us from being a really reactive to mental health and behavioral health issues to really proactive and early identification and prevention. Similar to what Vail said, is there's that large comorbidity. We know that people who have chronic illnesses, there's a high percentage who also have behavioral health or mental health issues going on as well, and largely unidentified and untreated. And we know that those people, if gone untreated and unidentified, cost the system 6 times more over time when we don't treat them together. And so we know that there's benefits, clinical benefits, by seeing the whole person and holistically. And we know that just better data leads to better outcomes, better treatment decisions. So having these touch points, having the data that really tells us the story, what's going on, what is making this patient a person, what's going on for them in their life, that maybe isn't showing up necessarily in the office or in their presentation as we're evaluating other things. There's lots of influences going on, and identifying those will help us make better treatment decisions. Those touch points are difficult, as we know, even if we have this long list of benefits to routine screening and assessment, we know that there's obstacles for doing it. Primarily, it's a lot of time, money, and human power. Traditionally, it is very manually driven, and that can be difficult, especially as Mike mentioned, as we expand the population in which we want to screen and monitor, scale becomes an issue. As well as traditionally, when we are trying to do those screenings and monitoring, we're doing them during our regular business hours as providers, and that's not necessarily when it's most convenient for patients. When we're able and to do that with our workforce, they're probably living life. They're at work, they're at daycare, doing carpool, things that really impede them from being able to engage in that type of screening and monitoring. So while lots of benefits, there are some major obstacles, traditionally at least, that prevent us from really doing them routinely. And I know, Carly, you've had some experience with ACOs and some of those obstacles and what you've seen work.
Sure, yeah. And so one thing that is a very effective way to help make sure that you're capturing the screening and in a efficient way that's not burdening your providers more is using virtual technologies. So assessments and screenings can be done, as Mike highlighted earlier, in advance of the actual appointment. So you have the opportunity to actually screen and identify, and is something that Videra Health, for example, is doing. And there's a number of solutions on the market, but one thing that we're doing is we can automate sending the assessment in advance, triggered based on on encounter or an upcoming appointment, for example. So you know that you're getting it in the right time frame. You get the patient can take the assessment in advance, and there's a video component. So you can ask question 10 with a video. And so you're getting feedback the same way you would if you were in that live interaction, and you're able to create, you get the scores, you get the feedback from the patient, and you're arming your clinicians before they've even seen the patient with the information they need to know whether the patient has some of those symptoms and what they may need to do with follow-up care or not. And so there's a lot of leverage and efficiency that can happen where you're taking the burden off their plate, but also making sure that you're still meeting the requirements and creating a really high fidelity clinical profile over time, where you can touch base annually on that front, and you have that same feedback again straight from the patient on that question 10 response, where you can really see how they're doing over time and create true baselines and longitudinal profiles, which we think is pretty exciting.
Well, and I think that highlights why it's not just sufficient to ask your patient, are you feeling sad or depressed? Right? Because, you know, they're likely to potentially get triggered by even the term depression, right? And they say, oh, that's not me, I you know, or like we talked about earlier, sadness might not be their predominant symptom. And so that's why you really need to use these standardized assessment tools like the PHQ-9 or the PHQ-2 to really get at the multifaceted ways in which depression might be presenting. And then to Carly's point, you can use that data to track over time, or even just to give that clinical snapshot. And that's so much more information, it's so much more valuable than just this one kind of how are you feeling question, right?
Absolutely. Well, you know, we've got some interesting real life examples where providers have used this particular assessment, and oftentimes they don't, you know, in a clinical setting, they don't like to ask question number 10, because then what do they do with all of that open-ended information, right? And sometimes, as you mentioned, Val, patients don't know how they're really feeling. So we had one instance comes to mind where a patient answered that they didn't have thoughts of self-harm, but when asked the open-ended question, they did actually share that they were having those thoughts and wishing they were better off dead and other things. And so there is a lot of value in adding the opportunity to just answer in an open-ended way or give more feedback than just those single questions, because they might not be presenting in that particular way.
Great. I thought you guys were going to keep going. That was awesome. Some fantastic conversation going on here, and really appreciate it. And remember, everybody out there, to ask your questions. If we get a chance to get to them, we will at the end. The next one I'd love to go to here is, and this hits home because I've been dealing with MIPS and with PQRS and value-based modifier and everything for 10 plus years now. And one of the hardest things is getting providers to buy into these quality programs. This takes it even a step further, because now you may have a cardiologist or a dermatologist that's going to need to do a depression screening on patients. So my question, I'm going to start off with Carly, is what are some ways to increase buy-in by providers to engage in quality measures, especially those that are seeing the all-payer quality for the first time?
Sure. Yeah, no, that's a great question. I think there's two key components. One, you have to make it easy, right? Like if you're adding burden to their plates, it's not going to happen, and you might as well just write it off. So you've got to make it easy. And that's again where technology and leveraging efficient technologies, where you can help automate and create clarity on, who owns the patient, especially where there's these like specialist relationships. That's where it can get really sticky sometimes. In a primary care environment, they know it's their panel. When you've got people that have chronic care conditions and they're seeing specialists, you've got to create clear visibility with the data and then help take it off their plates. So ways tactically that we've seen be effective are, one, again, you take the scheduling data and you automate sending out the depression screening in advance of the next appointment, because that way you're taking care of actually getting the assessment. You have the provider have the opportunity to follow up in case they didn't, but the patient will have that assessment still available on their phone or in their email where they could take it right there. And then you're capturing it all right there. So you have the actual record as well, that you've done it. So one, making it easy, taking it off their plates, automating as much as possible. And then two, you've got to give your teams the data. And the data part I know is really hard, but providers in general want to take care of their patients in the best way possible, right? Like they do want to give quality care. But again, you can't be making it more work to figure out how to give the quality care or who's missing. And so one thing that we found effective at Healthcare Partners was we created provider report cards, and it was about them and their population, and we highlighted where they were hitting the metrics and also the key points where they were missing, and we gave a hit list of the patients that were still missing and when they had appointments coming up next. So we tried to make it as easy as possible from a reporting perspective for them to know how they could engage and capture that information or those metrics from the patient when they were coming in next. We also showed them how they were doing relative to the rest of the population. I'd say providers in general are fairly competitive. And so that ended up being an effective thing as well, because they all want to provide quality care. And if they realize that they're, second quartile, not first quartile, that was highly incentivizing. And then the last thing that some organizations do, and I know not all, was also incentive payments, which depends on, again, whether you achieve shared savings. But if you're hitting those quality metrics, that certainly gets you much closer. Bill, what have you seen to be effective?
Yeah, I mean, I think removing the logistical barriers is huge, right? I mean, the last thing physicians and other providers need is one more thing for them to do when they're already strapped with their time. I think there also needs to be a cultural shift within an organization to support these type of practices, and often you need a champion that really is able to deliver the message of why we're doing this and why it's not just about checking a box and why it's not about proving that you're not doing a good job, right? Because I think in addition to being competitive, sometimes we can be defensive too, right? Like we don't always want to be measured because we don't want to be shown if we're not doing a good job. And so I think if you can change the messaging till it's about, giving you more tools to deliver the care that we know you want to deliver and to really provide, get your patient population as healthy as it possibly can be. And then ensuring that they have some control over how to influence those outcomes too. So I think one of the real challenges in the drawbacks I hear around depression screening is what if they screen positive and I don't know what to do? Right? And so we have to make sure that we're instituting infrastructures that provide that next step. So if they do screen positive, how do we get them to the care that they need, whether that's, again, additional assessment and evaluation, whether that's some sort of psychotherapy kind of treatment and or some sort of psychotherapy plus medication treatment. So I think those are also the things that we need to think about. So it's a multi-tiered process, right? So it's not just step one, but you have to think about, okay, and then step two, and then step three, and how do I build the structure that really supports my docs in a way that they can be effective and can feel like they're making a difference and not just either, again, checking boxes or trying to prove that, they're not doing a bad job.
Well, and that's where technology can again help leverage a little bit, right? Because if you screen and you're in a certain range, you can set up the automatic follow-up appointment, right? You can automate those types of things, and again, take that burden off of the initial provider's plate and create that care pathway flow where you're meeting the requirements, you're taking great care of your patients, and you're not creating additional work.
I think that that's part of that, one of those obstacles that impedes provider buy-in, because if I screen, if I do this, that just means more work for me. And so how to leverage technology, how to automate, how to create those workflows that I can, as a provider, do my best care, but then have a way forward, right? So a lot of technology, a lot of our interventions, a lot of these quality measures are geared towards how can we improve the life and the treatment of the patient. And even in technology, historically, it's been focused around how to make this convenient for the patient. And now we're starting to see, okay, but as providers, it also needs to be convenient, reasonable, and realistic for us. And if we do this, we can't necessarily just have unlimited resources to do something about it. And so it's really finding that balance with something that's convenient for the patient to engage, so we get the data that we need, but also once we have that the step forward is also convenient and reasonable for providers. And if that's lopsided and it's primarily geared towards just convenience for patients, then we're not going to get as much provider buy-in. And again, that's where technology can really help.
And Brett, this leads directly into our next question for you. And this one's for you is, what do you think are some of the best practices for leveraging these virtual technologies?
Yeah, this one for me is meaty. This one is like there's a lot into what virtual technologies are there, how to leverage them, and then what are the best practices, all in this context of routine screening and assessment monitoring for particularly depression, and the topic for today. So I have thought about and at Videra Health, when we were working with ACOs and healthcare organizations looking to leverage technology, a few things that we've learned. Definitely not comprehensive or exhaustive list, but a few things that I think we found helpful. The first being to acknowledge that we can't hire ourselves out of this problem. The obstacles that exist in doing this routine screening and monitoring are not going to be solved by just hiring more people to do it. There's more demand than we have the capacity to meet that demand, and just putting more hours to it isn't necessarily going to ever catch us up. So really acknowledging that that's a core problem, and also acknowledging that technology has to be a part of the solution, because we just won't catch up. We hear a lot of organizations, still doing the smiling and dialing, just a lot of people just getting on the phone, and for the most part it's 3 voicemails and no contact. People are really being able to get in touch with people, and so you try to do it when they're in office, and that just takes more of that limited time that you have, and that really takes away from providers doing what they do best, which is providing treatment, not survey management or questionnaire management. So really leveraging technology to ease that burden of the treatment related processes that we're required to do and that are good practice, and allowing providers to do what they do best, which is providing treatment. So again, acknowledging that we can't hire out of it, and technology needs to be part of the solution. Another thing that we found, again, as I mentioned, is just that balance between the patient and the provider. Convenience for the patients. Research that we've seen says that patients will engage in these types of screenings and monitorings and sort of these follow-ups if, 1, it's convenient, 2, that they feel like answering it will improve their health outcomes, that by doing this, something will be different, as opposed to, let's say, satisfaction surveys. We've traditionally asked patients a lot about how are we doing, and that is a little bit indirectly may influence how they get treated in the future, but right then, right now, doesn't necessarily help. So understanding that by responding to these types of screenings or engaging in these screenings will help me get better. And then third, that if something's off, if I'm screening positive, or if I'm meeting a certain threshold, that will lead to some sort of outreach or intervention or change in my care. So it's not this idea of like, I fill out a survey and it goes into a black hole. Maybe my provider does something with it, maybe not. And if they do, it's really just going to influence some future population or future patient, but it's not going to really affect me. So part of that, again, that best practice is having really making that live in the moment for the population as a whole, as well as for the patient. And in a way that scales for the provider. Again, if it just adds more work for the provider, we're going to continue to see limitations there. And ultimately that saves the healthcare organization, the ACO, FTE dollars, right? If we can leverage technology, if we can automate some of these processes, then we improve compliance and improve engagement with those, but also save time, but without really minimizing the clinical quality. So sometimes when we try to scale, we just get simpler. Like when we try to do more, then we just reduce the information or the quality of the information we get. And really that the best practice is to increase scale, but also maintain clinical quality, which again, technology will have to play a part in that. Feel free to jump in here, Carlene, Vale as well. I have a few more thoughts, but if there's anything that of those comments, feel free to jump in. Another piece of best practice that we've thought a lot about in my practice, but also here at Videra Health, which is the idea of just digitizing the traditional paper and pencil on a clipboard. So we went from that, or went from an interview, we've digitized it, but that's really just a small step in the right direction, but not enough to really impact again, the population as a whole. So digitizing paper screenings just isn't sufficient, isn't enough anymore. And we need more sophistication. We need more clinical robustness around what information are we getting at? What really is making this patient a person? What's driving them? What's impeding them from engaging in care? Depression is going to be one of those things. But as mentioned earlier, depression manifests in many different ways and also impacts people's lives in very many different ways. So one thing, as Carly mentioned earlier, that we've seen here at Videra Health is combining that qualitative, or the quantitative rather, information that you get, let's say from a traditional PHQ-9 with a single score and a threshold, as well as adding qualitative data, things that we normally look for, listen for when we're interacting with a patient, but does require us to be in front of a patient. And so when we add a video response to, let's say, a PHQ-9, you get nine multiple choice questions, but then that open-ended question at the end where traditionally they either have to write something, which limits the quality of the information we get, really allowing for a video response and allowing patients to respond pretty open-endedly about how they're doing. And we've been very surprised and pleased with the amount of information we get from patients when we're allowed to do that. And we know that from practice. We just usually had to be in the room to get that type of response, and that's not scalable. And we found that patients really don't like to be interrogated under a line of, in the last 2 weeks, how they, interrogated about how they're doing, but they do want to talk about how they're doing. Giving them the opportunity to do that, we glean a lot of clinical information about how they're doing, particularly with depression, because it can manifest in so many different ways. And finally, the method of technology use for leveraging virtual technologies. Traditionally, we've tried to do different things where we've sent patients surveys where they had to, find that link or log into an email or log into a portal, patient portal, download an app, lots of different obstacles that really just impeded them from doing so. But by removing those in any technology solution will improve interaction, improve engagement there, and doing it in a way that's meaningful across all age groups. There traditionally has been some hesitancy of how older age groups will engage with technology. And what we've really seen is, while there are differences, pretty much across all age groups, people are willing to engage with technology, especially when they have a belief that will improve their care. Grandparents are FaceTiming with grandkids and texting, and we're really seeing a shift in that, and the pandemic really escalated that shift into people's level of comfort with engaging with technology. So there's a couple high-level best practices or things to keep in mind if as you're choosing to leverage technology to consistently do routine monitoring and screening. Bill or Carly, any comments there?
Yeah, I mean, I think the only thing I would follow up on is, I think, like you mentioned, in the last 2 years, we've really seen the ways in which we can use technology in a synchronous manner right, in terms of delivering care with telehealth, whether that's video conferencing or audio only. And I do think we're going to continue to see this movement towards asynchronous care and how we use technology to meet people where they're at in their homes, not just in the 15 minutes that you get to see them. And I would encourage organizations to also think about, of course, how can you leverage ways to pay for this, right? Like how can you use this movement towards asynchronous care, whether it's remote patient monitoring or whether it's, behavioral screenings that you can get paid for. They're not a lot, but I think if you can, again, incorporate some of these components into your infrastructure from the start, and then you also have that kind of level of incentive to keep, to do this as part of your best practice.
Yeah, I appreciate that you brought up that asynchronous piece of it. We've been seeing that a lot in the market right now of how can we take things that have typically required synchronous or live interactions, whether that was in office or over traditional live telehealth, and scale those types of interactions. At Videra Health, we can really preload some of those even clinical interviews beyond just even a screening for PHQ-9 or depression, but some of those follow-up questions we might have as providers of, okay, you screened positive, but let me ask a few follow-up questions and get some feedback, and we can preload all of that into an asynchronous experience. So think of a semi-structured interview that a patient can be self-guided through at their own convenience. It could be 9 p.m. after they get off of third shift, whatever it is, and do that at scale. Hundreds, if not thousands of people a day or week being able to have a seemingly interactive experience with a provider, but a provider is not necessarily live on the other side. And when we have those types of asynchronous interactions, we can also do a lot of analysis on that. Similar to, again, what we would be doing if we were face-to-face with a patient, we'd be listening for rate of speech, sentiment, affect, how they're presenting, verbals, nonverbals. And as providers, we've been trained to interact that way. And if we have this recorded video responses, we can actually start to teach machine learning and computer algorithms to look for and listen for those same things. And between the qualitative and the quantitative, really be able to meaningfully and robustly identify those who are struggling, even beyond just a PHQ-9 score. So Carly mentioned an example where somebody on a multiple choice question just said no, but once we've had meaningful interaction with them, we realize actually there's a lot more going on there. And how to have that type of interaction at scale is something that we focus a lot on here at Videra Health.
Great. All right, now I'll interrupt. Let's go on to the next question here. We have about 15 minutes left. We do have a couple questions that came in, so just let's keep going. All right. Is there an ROI to utilizing virtual technologies? I'm going to send this one over to Carly.
Yeah, thanks. So yeah, there's 100% ROI. You all know your populations best and what an ED visit costs you in your geography. So I'm not going to throw out specific numbers, although if you want to walk through examples offline, I'd be happy to walk through the tangible examples offline. But the way that we like to think about it is you have your care management team that's following up and engaging with those identified high-risk members. Now, if you're doing the depression screening along with all of your other screenings, you're going to identify those individuals that may need a higher touch engagement. If you think about how much you can afford to staff up to have a care management team the size that would really touch everyone that needs some sort of engagement, it's generally not feasible. So how do you do that? You use a technology to touch base on a more frequent basis where the patients know it's about me, not about the healthcare provider, right? So I'm telling you how I'm doing. And they know that if they escalate something and say, yeah, I'm feeling more down in the case of depression, that it's going to go to your nurse care management team and they're going to engage. The way that we see the ROI flowing through for value-based entities in general and ACOs in particular is that reduction in ED and hospital inpatient admissions, because you have the visibility to better manage the population and see when those individual patients need help that you just wouldn't have the visibility to otherwise. And that lifts the burden off of your talented care management team from having to do all the dialing to find those needles in a haystack, so to speak, and rather they're reaching out to the people where there has been alert trigger, that somebody has said, like, I'm not feeling great, or my medication isn't working right, or I don't really understand my post-discharge instructions, so can someone give me a call? So they are looking for that engagement. So it increases also your clinical team satisfaction, because because they're spending time actually helping people that need help and want help, rather than trying to find the people that need help. And so I think there's a really a virtuous circle here, in that you're getting more information from patients, because you're also, as we've talked about, is asynchronous a lot, you're touching base when it's convenient for them. So it's not just the 9 to 5 period. And so you're going to get more information, not only because of, if you're using Videra Health, video, but also because of the information that's coming through. And then you can risk stratify and spend more time with those patients that are at higher risk. Phil, what else have you seen?
Yeah, I mean, I think you hit on all the really important points. I think, you know, sometimes you have to invest in order to actually get the outcomes that you want. And investing does require, obviously, resources on the front end, right? Whether that's financial resources or time resources or, you know, sort of strategic resources to really make it work. But I do think that in the long run, you know, not only do your organization see the ROI that you need to see in order to survive, but I think it's the ethical and the right thing to do when we're thinking about how do we deliver quality healthcare in this country. And so I think it just, you know, we get into these fields because we want to help people. And to give people the tools that they need to do the best job possible, I think, again, it's not just a financial ROI. I think it's, you know, it's just the right thing to do.
Yeah, the ability to understand somebody's emotional state at any given time without requiring them to be in front of us is a powerful concept. And we've been able to do things like that in other chronic illnesses. So we have this continuous monitoring, so we know where somebody is. But when it comes to mental health and behavioral health, we quite haven't done that yet. And we feel that routine screening and monitoring, with the addition of qualitative video data, is really that window, that lens into which we can see what's really driving our population. And again, when it at the end of the day comes down to some of that money, what's driving costs, where can we identify opportunity to be preventative and thus save dollars, reduce FTE count. One big ROI again is the cost of doing the routine monitoring. Can we reduce that cost by leveraging technology? And we've seen, you know, technology being able to do routine monitoring at 25% of the cost of a traditional FTE to try to do that. So we really are seeing financial ROI, as well as you mentioned, Val, being the right thing to do for ACOs and healthcare organizations to engage in this type of screening.
And I think the other point I would make, you know, I think it's important to take some lessons learned as we think about the role that technology is going to continue to play in healthcare. Obviously, with the explosion of the electronic health record, there was a lot of promise on how it was going to improve efficiencies, and I think it probably has in some ways, but it's clearly created burdens on physicians and others in other ways. So I think we want to be thinking very strategically, like, how can we use technology to reduce burden? And then I think you will see happier providers, right? And then you will have less burnout, you'll have less turnover, and that in and of itself is a huge ROI.
Yeah, data is the currency, the healthcare currency of the future. Somebody said once, you know, if cash is king in business, somebody said then data is queen. Data and what we know about our patients at a population level all the way down to personalized healthcare. Patients are expecting that. What data do we have about somebody at an individual level, at a cohort level, at a population level will really ultimately dictate and drive outcomes in the future. So as much as we can leverage technology to have good insight into that longitudinal view of what's going on with patients. I mean, imagine if we had data across time for somebody who's experiencing bipolar, and so we know what Susan looks like, sounds like, talks like during a manic episode, but because we've been screening and monitoring, we also know what she looks like, talks like, and sounds like before a manic episode. And being that the power that comes with leveraging data and big data, but doing it for good, doing it for the benefit of the patient as well as the benefit for the providers is really where healthcare is going.
Great conversation. All right, we do have a couple questions. One, hits home to me as we are discussing a lot in the ACOs about health equity. There's new measures about health equity that will be included in ACO reporting in the future. There are now MIPS measures about health equity. In the final rule, there was over 700 times the name health equity was added to the rule. So obviously CMS is starting to really change some of the conversation of what it looks like. So the question that came in is, with the increased awareness of health equity, how can virtual technology help providers meet some of these expectations? So I'll open it to the team.
I'll jump in first. I think there's a couple of interesting ways. One is access, because if you think about health equity, I mean, there's food deserts and there's provider deserts too, right? If you think about access to high quality care, right, in particular geographies. And so when you start leveraging virtual technologies, you give the opportunity to give feedback and also potentially get engagement without having to hop on a bus and go across town or whatever the case may be from an access perspective. And then on the assessment side, we also remove bias, because we inherently have bias as humans. And so if you're using a technology to do the screening and analyze what people are saying or how they are saying it, you're creating a true standardized baseline for both the individual and also your population. And how much better can you do tailored treatment and true measurement-based care for a population if you have the data and the measures of where they started and then looking at where you want to take them? What else would you add in? Yeah,
I'll add in there that it's for so long we've just had patients come to us, and to a degree we have to start meeting them where they're at. We know that 80% of what predicts long-term health outcomes is what happens outside of the office in real life, where patients, in the wild, and we really have to meet them where they're at, where life is happening, and get insight into what's going on there. And only by doing that will we understand at a population level how to close those health equity gaps. But having them just come into a controlled environment where we have just very limited information about what's really going on isn't going to help us gain any insight into what they're experiencing outside.
And to bring it to even a granular level, I mean, this depression measure itself is actually a health equity measure, right? Because we know individuals from communities of color are less likely to be diagnosed, screened, and treated for depression, even though they have depression. And so I think just the actual act of implementing routine screening across your population in a way that, again, doesn't touch on some of the biases maybe that Carly had mentioned earlier, I think, again, it's just is a small step that we can even take towards better health equity.
Great. All right. So with 5 minutes left, I'm going to take a step back, ask each one of you one more question, and then we're going to let everybody go. So I'll start with, I guess it's going to be the same question for everybody. Give me your final thoughts. Tell me what you want to see out of what we did today and where it goes. So let's start with Carly.
Sure. Thanks, Mike. I'd love to see people leverage technology to get more information from patients, see where they're at, and then take the lift off of providers of surveilling the population and getting that information so that they can just do the work of taking care of patients.
Great. Thank you, Brett.
Yeah, I'd say take the leap. Take the leap. We already have to be doing it. And so let's make it easier on ourselves by leveraging technology, being able to really partner to identify what is going to move the needle for your organization on this, to do, and really with the ultimate goal to improve patients' lives, right? It's out there, it's happening. By not screening it doesn't mean it's not, it's gone away. It's there, and so we do need to just take the time and take the effort to move forward in leveraging technology to improve care.
Great, Brett and Vale.
I think that to call COVID a disruptor is probably an understatement, but I think it's created some really incredible disruption in a positive way. Not just the inclusion of telehealth, but the way in which we're having these discussions about how our physical health and our mental health are so intrinsically entwined. I think in ways that we just weren't before this. And I think the mental health effects from the pandemic and everything associated with the pandemic are going to be longstanding. And so I think it's in the best interest of organizations to be thinking about what are the multiple solutions that we need to implement in order to treat a holistic patient population. And that's going to include things like greater emphasis on prevention, meeting people where they're at, like we talked about, integrating behavioral health care within your physical health spaces, whether it's specialty care or, again, primary care, and it's going to include technology and responsible intervention. And so I think that that's really what I hope individuals take away from, that how can you leverage value-based payment models that are coming and that are meant to drive quality? How can you really leverage them in a way that works for you, that isn't just checking boxes and getting paid, but actually improving the holistic health of your patient population?
Fantastic, Val. That was well said. Well said by all of you. Really appreciate everybody's time today. Thank you for coming on. I will be sending out this video as well as the slide deck to everybody sometime this afternoon. What I would want to get out of this is I'd love for you to call us and find out how we could help with the APA and Videra to help you accomplish some of your obstacles that are ahead of you with this measure and with this reporting. So appreciate everybody's time. Thank you once again, and everybody have a great day.